your
Except it's
face.
not the other way around. Well, now you do.
There we go.
Hi.
See?
Hold on. Okay.
All right, we're here. How you doing?
I'm doing good now that we're signed on. You made me anxious there.
Sorry. Well, I bet you have a cure for that, right?
Well, yeah, it's a good thing I know what to do.
The breathing exercises. I don't know.
No, just accept it. Like, we're going to be late. It's going to be what it is. I'm going to be able to show that I've never used Instagram before, and that's going to be okay.
Awesome. But now you're a pro. So.
Well, I'm learning it.
Yeah, I mean, you don't want to be too much of a pro because then they might make you like log on sometimes and.
Yeah, no, I'm definitely not a pro.
Okay, so do you want to give a little bit of an intro about yourself, your background, and kind of why this topic?
Why you called me?
Uh-huh.
I don't know why you called me.
Well, Rachel Tuffman. I actually called Rachel Tuffman, and I'm like, okay, right. I need to do this topic. Who is the guy to call? And she recommended you. Like, first, hands down. She's like, you got to call him.
That's very kind of Rachel. I can tell you about what I do professionally. Maybe that's a good way to start. Okay, so two things, two hats. The first is that I live in Boston, and I work at a place called McLean Hospital, and that is a psychiatric hospital, and it's associated with the Harvard Medical School. It's a psychiatric teaching hospital, and I'm an assistant professor in the Department of Psychiatry at the medical school, and I study spiritual and religious issues, actually, as they pertain to mental health, to treatment, to the course of disorders, and also religious communities, how things play out, including the Jewish community. So that's one of my hats. The other hat is in New York, and I have a clinical practice there, which now, thank God, has grown quite big. We're at about 30 staff.
Yeah, I see one. Eliza Tropper just came on.
Yeah, hey, Eliza. Hey, how you doing?
We've had
one of my clinicians.
She's awesome.
Yeah. So yeah, she is awesome. And she works in my Brooklyn office. We have offices. The program is called the Center for Anxiety. You can find us on the web at centerforanxiety.org. And we service 600 or so new patients every year. Many from the Orthodox community, but not exclusively at all. Let's say 25 to 40% of our patients are from the community, but also beyond as well, well beyond. And we have offices in Manhattan and in Brooklyn and also in Rockland County in Muncie. So that's what I do professionally. Recently, I wrote an article for Jewish Action, which is the Orthodox Union's magazine. I think it's published quarterly. The article was called Dating with a Mental Disorder. And that was about dating with a mental disorder and what it's like and what people, what does clinical science have to say about it. So I'm guessing that's why Rachel sent you my way.
Yeah, and I talked to you that I was going to repost it on our website, so we did, and hopefully a lot of the people who are on here tonight did read it in advance. Maybe they didn't.
If not, then they can catch up now as we're chatting.
Yeah.
Perfect.
Yeah, so but it was a really important topic when, like, what was the impetus of the
article?
Right? Yeah.
The sheer volume of calls that I get, as the director of this clinic, which is pretty busy, a lot of people call me up for advice, and they, I keep getting questions such as, hey, my son has been dating someone, it's been going really well, and she just mentioned that, her, paternal aunt had schizophrenia. Should we go ahead with the shoulda? Do we break it off? We're not at engagement yet. Or people who tell me, hey, I'm about to get engaged, and she doesn't know that I've had OCD for 3 years. I'm really scared. I don't want to lose this. I lost my last shoulda because of this, and I'm terrified. Or people who are in the middle of a marriage and they're dealing with the mental health issue, and what do they do? How do they handle it? How do they, they either do have kids yet or they don't have kids yet. I get a lot of questions about this kind of stuff. So I figured putting pen to paper and really articulating some broad brushstroke, really like a position statement on it would potentially have a readership. And Jewish Action agreed, and they published it.
And what was the response like? Did you get a lot of people like, thank you so much for clearing things up? I didn't really understand mental illness before.
I don't know about that. I definitely got positive responses almost across the board, almost without exception. I think people appreciated just tackling the subject matter. Often we shy away from even dealing with or talking about mental health issues. I think that's decreased in recent years. We do handle it better, actually fairly well now as a community. At least many factions of the community do. But so I think people appreciated the fact that it was dealt with. And I also think I have a hopeful message and one that's grounded in clinical science. So.
All right, well, let's hear that hopeful message.
What's the message? Well, let's start with the negatives first.
Oh, okay.
So the bad news is that if you look at the base rates for mental health disorders in the United States, and Canada's no better, sorry, where I'm from, by the way.
I'm from Canada, too.
I know. Native Torontonian over here. So, well, not much better anyway. If you're looking at nearly 50% of Americans in a given year have some sort of diagnosable condition. That's like a certifiable, insurance reimbursable treatment, and it warrants professional treatment that's reimbursable by insurance in theory. So we're talking about like significant distress or impairment. I don't mean like a little bit of depression or a little sadness or a little anxiety. You get stressed out sometimes. You kind of have to take a breather. That's everybody. That's literally 100%. Mm-hmm. If somebody doesn't have that, then I worry. But or people who cope with the anger, or drink a little too much at kiddish once in a while. Not to say that's nothing. It isn't. But I'm talking about people with significant distress or impairment is nearly 50% of the population. And in the Orthodox community, we don't have any base rates. There are not any data, but I've done a fair amount of research empirical research, scientific studies. And I'm just looking now. We're in the studies that I've done, 21 to 30% of the Orthodox Jews in our studies are either taking psychiatric medications or receiving treatment or have a diagnosable disorder. So that's like 1 in 4, 1 in 3.
So it's probably likely that if somebody's in the dating scene that they're going.
Yeah.
Yeah.
I mean, take a guess. Like if you have, put it this way, if you have like 3 kids in a family, 4 kids in a family, like this is just, it'd be very strange for one of them not to either have an issue. And if all 4 of them get married, then you're talking about 8 people. So you're looking at like at least 2 out of 8. And if all of them have 2 kids, which is pretty small by Orthodox standards, then just do the math. I mean, there's in a classroom of 30 girls, you're looking at 8 to 10. So we can't avoid it. Like you're not going to avoid mental health concerns in a marriage today. I mean, maybe, but it's statistically unlikely that you're not going to deal with this. It's not the kind of thing that we can avoid dealing with.
But also, even if you did marry somebody and they didn't have anything
right
pre-existing, that's not to guarantee that
not at all
happen after.
Not at all. Sometimes people who have had mental health concerns are more resilient because they've dealt with it, they know what to do, and then when they hit a road bump later in life, hey, I've actually trod this path or something so similar enough, as opposed to people who are like perfect, adel girl who never had a problem, straight A's, beautiful, gorgeous, wonderful, amazing family, and like she hits a distressing patch later on in life. Or same thing with Mr. Perfect, who was like, straight A, valedictorian, top of his class, best yeshiva, did awesome, and then they hit a roadblock and they're like, oh my God, my entire life is crashing. So it's not necessarily a good thing to have no disorder, no history, no mental health history, not at all.
Well, like someone that I'm really, really close with was diagnosed with a mental illness, and she's literally the most mentally healthy person that I know. Like, I've never met anybody in my life more mentally healthy than this person suffering with a mental illness, because she has to be on it. Right.
But it assumes that they're on it. And that's the sort of the position that I take on this, is that you can't avoid it. So therefore, what's the only question? Whether you're willing to deal with it and whether you have the capacity to deal with it. Willing to deal with it and whether you have the capacity. I'll deal with capacity first. Some people, unfortunately, they just don't have access to treatment. They might live in an area of the country where it's very hard to access evidence-based treatments for the problems that they have. If people are in, if you're in the New York area, and there's good culturally sensitive evidence-based treatment for pretty much any disorder that you have. In Israel, it's not as common. In Canada, it's an issue. In Toronto, I got a lot of referrals from Toronto because mental health up there it's getting better, but there are concerns from back home where I'm from. In the Midwest,
proactive
100%
stuff going on over here.
Mm-hmm. There's also the healthcare system. New York is much more proactive, and also the economy of scale is enough that you have reputable, sizable institutions that are able to handle the burden of providing for people, and the economics of it makes sense. In Canada, where you have single payer, it's government payers for insurance, and everything is out of pocket then because it's in the mental health world. Situations like that can make a massive difference because people then don't have access to care.
Yeah, for sure.
So unfortunately, that's the reality. When people call me up from South Florida, like I have a couple people to refer to down there, but it's not nearly the same as if they're in, an urban center where they can get what they need.
What about like online support?
So online support depends on the nature of the concern. Certain things, it's not a problem. If you have, if it's OCD, depression, anxiety, I'm much less concerned. Really across the board.
It's harder to do like EMDR treatment on.
I'm not sure I would go with EMDR even on a good day, to be perfectly honest.
Really?
But, yeah, I don't know. The jury's definitely out on whether the eye movements do anything, but I don't want to get too far afield. People swear by it, but I'm not convinced by the data on the eye movements piece. The reprocessing, there's something there. But in any event, that's another thing, is that many subcultures within the Orthodox community gravitate towards treatments that have not been adequately validated. I don't want to typecast certain areas, certain groups within the community, but like things like St. John's Wort or Valerian, like they're good group. They're known groups within the community that like that's what they will do, as opposed to things like behavioral activation or cognitive therapy or depression, or getting people activated socially, or even getting them more involved in spiritual activity where there's data to support that, especially in our community, if they want that kind of treatment. So the point is that if people can't access high level, scientifically validated, culturally sensitive care, that could be an issue. And sometimes finances are an issue. Sometimes finances are the barrier. They just, the reality is if people have moderate to severe OCD or depression, you're looking at thousands of dollars of treatment, no matter how you slice it. And that means that socioeconomics, unfortunately, are going to be a factor, or people's willingness to invest.
So if there's socioeconomic issues and a date is suggested, like a guy is suggested.
My two questions are not whether there's an issue, but do they have access to care, and are they willing to do whatever it takes? If they're willing to do whatever it takes and they have access to care, I'm much less concerned, even if it's a serious problem. I've seen patients come in with psychotic disorders, okay, which are, by all definitions in mental health, serious. Mm-hmm. They're serious. People are seeing things, hearing things, they're out of touch with reality. I've had patients who come in, they have access to care, they have supportive families, the means to pay for treatment, they have found practitioners who are culturally sensitive, who they can connect with, who can deploy evidence-based treatments in combination with the pharmacologist or without, in order to help the patient. And in this case, the guy was willing to do anything, whatever it took, which even meant for this person, a very, very avid learner, scaling back learning, taking breaks, like being more recreational. There were social consequences, but the person's like, that's it. Like, I have to do this. This is what my doctor said. And honestly, I think he's a great candidate for marriage.
Okay. Well, then how would the person looking into him know that?
Okay, so the question of disclosure. Just let me round out this one point, and then I'll talk about the disclosure. When people aren't willing to do whatever it takes, I would stay away. And
that would be with or without a mental illness.
I agree. It's not specific to mental disorders.
Right.
But if people aren't willing to own their stuff, to own what it is that they have to deal with in this world, just stay away. I mean, that's not the kind of person you want to, get involved with, because those issues will grow over time. If you ignore them, they'll grow over time, get swept under the rug. And if the person's not willing to deal with it, it just becomes intolerable at a certain point. And that can break apart marriages. That's dangerous. That's actually dangerous. But much more than someone who if someone comes to me and says, I have bipolar, I'm never going to get married. No, my first question is, do you have access to care? And are you willing to do whatever it takes? And if so, then there's a lot less to worry about.
Well, the only thing really to worry about then would be stigma. Which is what we got to talk about.
So let's talk about the stigma.
Mm-hmm.
Okay. First things first. There's a lot less stigma today than there ever was when it comes to mental health issues in the Orthodox community. I think not everybody, but people are much more savvy than we ever have been. It used to be the case that we didn't talk about these things, but I think today often these conversations are being had publicly in many cases. And I think I think a lot of rabbis today and a lot of people who are leaders in the community are very savvy when it comes to mental health issues. Just today, I was speaking to a Rav in the Midwest about a situation that he's dealing with some of his congregants. He really knows the ins and outs of what's going on in marriage and mental health issues on both sides. And
Midwest isn't a good gauge because they're ahead with all mental health.
Really?
Oh, yeah. The Chicago, I was just talking to Yankee Greenberger from, he started Madrigos. I think he's on the line.
Sure.
Or he was part of building. They're just so proactive in Chicago. They do the best proactive programming that I've ever witnessed.
Interesting. Okay.
Yeah. Because I guess they have a small town mentality with a big city vibe. So they're really able to pull through a lot of stuff that other communities haven't been able to pull through.
Yeah. Okay. Good. Yeah, I don't think it's only there though. I think it's not across the board and it's not in all factions of the community at all. But I think there's a lot more sensitivity and knowledge of it. I also think that families are a lot more forgiving these days about it. I've been told, and I don't know whether it's true, but I've been told by patients that being on anti-anxiety medications these days, it's like not even an issue. Like Klonopin, Xanax, other benzodiazepines, which are probably my least favorite, by the way, from an anxiety, treatment standpoint for reasons that go beyond our discussion. But they, often is not even held against. It's like, okay, like people have anxiety. It's like people take Advil for headaches and they take, medications for anxiety. Like that's just the way it is today.
Oh, wow.
Yeah. And I'm talking in right-wing, in right-wing factions, in yeshivish and even Hasidish circles to some degree. There's a lot more forgiveness and understanding about these issues just because the base rates are so high. Mm-hmm. So I think a lot has changed, and sometimes people are really terrified about disclosure. Remember that, if you're dating someone and you've been hiding something or thinking about disclosing and it's early on, and often they're thinking the exact same thing. They want to disclose to you as well, or they want to disclose about a family member. I mean, statistically, there's a good chance that at least somebody on their side as well has an issue.
Which is another good question is like, if both sides have an issue, is there like a genetic, like I've heard that come up too.
Yeah, we can talk about genetics. Just to round out the disclosure piece, so it depends on where in the community people are holding, and on the modern side, it's obviously a little bit longer than this, but typically in your mainstream yeshiva Orthodox culture today, the standard typically is between 4 and 5 dates, 3 and 5 days of people disclosing.
But you don't think that the shadchans find out before?
So about shadchans, I've seen shadchanim make a big mess when it comes to mental health issues. And I've, in general, discouraged people from disclosing mental health issues to shadchanim for that reason. I think, the way it used to be where you have a shadchan that you know personally, and that's someone who's a family friend or maybe even a family member, then I would disclose. And they have to know about you and advocate for you and be a champion for you and also protect you from somebody who's not going to understand you. You don't want to go ahead with dating someone and then have your heart broken. Mm-hmm. So that's, when I would disclose to a shadchan, but a third party who's basically being paid in order to make matches, that's where you have that, frankly, a conflict of interest. And I think that can breed, the economics of that situation can breed issues about disclosure that are not necessarily favorable to either party. So I would be more careful with sort of your traditional shadchanis, not to mention word travels like wildfire, and all of a sudden you have people who are chatting, and you have to be careful when it comes to.
But what about like just people find out in the communities? So like if somebody in the family was at a treatment center, like everyone's gonna know, right? So is it something? But isn't that part of the destigmatizing? Like everybody has something going on,
Firstly, not everybody's going to know when a person goes to a treatment center. There are a lot of reasons why. These things are often, people don't necessarily talk about it. I don't think you can make that assumption. I've seen a lot of, McLean hospitals have really, it's one of the top places to get care in the world. And we see a lot of private pay people coming through to some of the higher end programs, including many, names that you would recognize from the Orthodox community, from the international Orthodox community. And me, by being on staff there, I'm often called in as a consultant. Also in the Center for Anxiety, we get a lot of high-end patients. A lot of high-end patients will come to my New York office. I don't think there's as much of a stigma anymore for treatment seeking.
Well, I just heard somebody wrote in about that they're nervous about getting one of their kids help.
I saw that.
Because because their other kids are in the dating scene, and they're worried that if anybody found out that it could. But I mean, to me, like it just seems like in every family at some point there's gonna. I mean, what you were saying, that at some point everybody's family will probably have to be dealing with it.
Truth is, from a strategic standpoint, I think it's probably dumb not to get your kid treatment, because then what's going to end up happening is they're going to need more severe treatment. If you're just sweeping it under the rug with kid A in order to protect kids B and C and D or whatever, what's going to happen to kid A? Everything's going to blow up, and then you're going to have a much bigger issue to handle. Not to mention the message that you're sending to the other kids, which is, when you have a mental health problem, sweep it under the rug and do not deal with it. That's a pernicious message which is going to come out and cause all sorts of havoc in their lives and in their marriages. So I don't think that's an excuse or a reason not to get treatment for a kid. I think that's a really bad practice. I do think it's a reason to be discreet about it and to be careful and to find people who you can trust, and to be strategic about it. But that doesn't mean not to get help. That's just a bad idea.
Oh, yeah. That makes sense.
Frankly. You asked me a question before, not about disclosure. Oh, genetics.
Mm-hmm.
Genetics. Yeah, I wrote about it in my article, just a little bit, although it's probably worthy of a whole other article. I'll be honest. The more I go to genetics talks at national conferences, like I'll go to scientific conferences, and I'm usually presenting and doing my thing, not on genetics, that's not my area, but on my own research. And I like going to genetics talks because the more I read and learn and hear about the genetic bases of mental health disorders, the more I see how little of mental health is fully grounded within a genetic framework. Firstly,
are you talking because of intergenerational trauma, like from that perspective?
No, yeah, the intergenerational trauma is interesting. One of the factors there is that we see that there's epigenetics, that in fact there are environmental factors that can turn on or off certain genetic, predispositions, if you will, which is a nice way of saying that it's a lot more about your environment than your genes, right? And there's good data to support that. But the other issue is that if you look at even highly rated genes for certain disorders like depression, what you see is that there are sort of obvious statistical issues, and the recent data that's coming out is washing a lot of those results away. So certainly when it comes to unipolar depression, the genetic bases are not very compelling, according to the current science. Even for postpartum depression, people often say postpartum is different. It's much more biologically based. Like I'm not sure. I'm not sure about that. I think the stressors of being in the postpartum period, new baby, often work changes, relationship changes, hormonal factors, lack of sleep, identity aspects, like do I want this baby, then feeling bad about having, do I not wanting the baby, having questions about that, how do you feel? It brings up a lot for people, plus the hormonal changes. All of that is all of those are very significant environmental factors, which, can predispose, frankly, a person to experiencing symptoms of depression, much more so than the genetics.
On one of our lives, so we kind of compared it, I can't remember who it was with, we compared it to like a genetic predisposition for like a cancer gene. So if you're exposed to the environmental factors, then you'll likely get cancer. But if you're not exposed to something that will trigger the cancer, I'm not a doctor, so it's not going to come.
I get what you're saying. It gets turned on or off. There's just one difference, though, when it comes to mental health, though, which is very critical, which is more magnified in the mental health world than it is in cancer, and that's the role of behavior. One of the and also cognitive, like the way people think about things. So one of the chief determinants of the course of a mental disorder is the way in which a person thinks about their life and the way in which they behaved. So if you have a propensity towards depression, but you know you're getting depressed, you get on a treadmill, you get out there, put on your makeup, go out with your friends, hang out, fake it till you make it, that could in of itself prevent depressive episodes from happening and help a person to get out of them in many cases. And it's also a very adaptive, healthy way of dealing with them. To keep moving, just to keep moving. So that's a behavioral factor, right? Those are, and also what supports do people have, and to be able to pull that off.
So that's with depression, but what about something a little bit more serious? Right. That would. Yeah.
So genetic basis
not
for
to
talking
say
about.
That it's not serious.
No, I know depression can be serious. Depends. Yeah. But you're talking about something like psychotic disorders or bipolar. Let's talk about bipolar first.
Okay.
Firstly, bipolar is often misdiagnosed. And often bipolar is really more like a borderline. Borderline is much more common than bipolar. And borderline personality disorder involves lots of difficulty regulating a person's emotions. So people who have borderline are often full of emotions, tons of raging emotions, either really hot, really cold, really excited, really down, really euphoric, and that starts to sound a lot like mania, where people are really high, hyper excited, and then they have a tendency to also get down. The difference is that bipolar is usually cycling over days, where people are high, hyper excited for multiple days. For borderline, it's within a day. So they could be like really, really excited in the morning, and in the afternoon, they're like crash. Or even an hour later. And then 1 hour, and then a couple minutes later, they're feeling really excited and hyper again. So often the presentation of it gets misdiagnosed. When it comes to borderline, there's almost no genetic basis for it. Not to mention pharmacology is much less effective. Much less effective. When it comes to bipolar, so the genetic bases are more, but more for bipolar 1 than bipolar 2. Bipolar 1 being like 7-day manic period, as opposed to 3 to 4 days. So it really depends on the severity of the situation. And again, I wouldn't just say like, oh, bipolar, genetics, can't marry them, it's going to mess up my kids. It's not so simple at all.
So what would you say if somebody said, I think I might have had an aunt that has bipolar, and I just got suggested a shidduch for my son,
right.
to a girl who has bipolar.
Right. So I would say bipolar 1 or bipolar 2, is it borderline? Where were they diagnosed? Do they have a hospital? Were they ever hospitalized? Is there a hospitalization record? I'm going to ask some more specific questions. Based on what you told me, there's nothing there. I don't know what that even means. I get those questions all the time. I think someone might have bipolar in their family. Does that mean we can't marry them? Well, I don't know what that means. If we have a clear diagnosis from a tier 1 hospital that they definitely had bipolar 1 with multiple episodes leading to hospitalization and severe functional impairment, okay, then maybe we have something to talk about there in terms of genetics. But even then, the environmental factors are going to be more significant to me, and the behavioral factors. Is the person willing to own their peace? Do they get enough sleep? Do they regulate their diet? If they're on medications, do they take their medications no matter what, even though they're having side effects, and manage to get through that?
And if that's the case, then there shouldn't be any reason.
Listen, it's up to each individual. I'm not going to say it's a slam dunk, go for it, but they might be trading, they're not necessarily trading a bad situation for a better one. It might be for a much worse one.
Mm-hmm.
I wrote this in my article, and I'll kind of say it here. In many ways, I think a person's better off marrying someone with a more significant, clear emotional disorder who is willing to take care of it and has the means to do so, than someone who has an emotional problem, even if it's below a disordered level, but they're not willing to face the music of who they are.
That makes sense.
My position.
We had a bunch of questions. Should we scroll back and answer those questions now, or
Your show.
All right, let me scroll back because I feel like we're getting a little behind on the questions.
Sure thing.
All right, let's see. Okay. How does someone assess whether the person is following the treatment program that is designed for their...
How does someone assess whether someone else is following their treatment program?
Yeah, like, I guess the question it was, like, how do you know if the person is...
Best case scenario, when someone's had a mental disorder, is they come clean to the person who they've been dating. That other person accepts them, but then has questions and wants to get involved. And that other person calls me. And I have the full permission of the other person, my patient, to talk openly with their prospective suitor about what's going on. And we can have open, adult, collegial conversations in order to provide the support that they need. That's happened a number of times. A patient with severe OCD, an older female, all of 27, and she came for quite a bit of treatment. I mean, she was with me for a while, and did very well in treatment, but it was excruciatingly hard for her. And then she started dating and found a guy, was getting serious, told him about her mental health history. And she said, I'd like you to meet with him. I want you to speak with him. And I said, is there anything you don't want me to say? Like, no. Like, I want you to be upfront, and I want you to, tell him what he needs to know in order to support me. And it was amazing. That's exactly like textbook how it should be. I understand that can't always be that way.
Right.
For a variety of external factors, but if I could write the script.
Wow. Okay. Somebody else asked, is it right of a prospective shidduch to ask to see a hospital record before even agreeing to go out?
That's kind of what we were speaking about before. I mean, listen, you can ask for anything before you go out with someone. You want to ask for their net worth, go ahead. Go ahead. You can ask for any information you want. I just think when it comes to mental health, that if you want to know whether they have a diagnosis or not, you're missing the main question. The main question is, are you willing to own who you are and what you have to deal with in this world?
Right.
Are you a human being? Let me ask you. Are you a human being?
Are you asking me?
Yeah.
I like to think I am.
Me too. So I am also. That means that you have baggage. And guess what? So do I. And that's life. The only question is, do you own it? Do you own it? Do you know what that is, what your baggage is, what you have to carry, how you have to deal with it? And do you have a plan for doing so? And can you share that with your loved ones? Can you be really open and honest and upfront with the people who you love? Not with everybody. Don't put it on Instagram or Facebook or some brave souls do that, and power to them. But I don't think you have to advertise it. But I do think that when you're talking about marriage, we have to be able to be upfront with the people who we're gonna be living with, and because they're gonna know. By the way, they're gonna know.
Yeah, but even if you think that you're buying into a family that's like sunshine and rainbows, like, you don't know what you're getting into, really.
They're gonna know once they marry you.
Right. No, but I'm saying like who really? You could check all the, spreadsheets that they give you about the guy, but you don't really know what you're getting into.
Oh, I hear what you're saying. Yeah, 100%. 100%.
I mean, there's so many shidduchs that like work out beautifully with when both of them have mental health and mental illness concerns, and some of them that you've no idea what you're getting into, and all of a sudden you're like married and you're like, oh, I didn't know that the father was like a rageaholic, and I hear stories all the time where you have no idea, even the most perfect families, like, or seemingly perfect families, you don't know. At least the people who tell you about the mental health issues, like, they're disclosing.
Right. It's a good sign that they're going to be dealing with it because they know what the issue is, or they're willing to accept it.
Right. That's what I think. But
I would agree.
and then I said, yikes, the shit F world is brutal.
Yeah, life is complicated. I don't think it's just a shit F world. It's complicated today.
Someone else said, I'd rather go out with someone who has an issue that they take care of than someone who doesn't have any issues. Yes.
Bingo. That's my message. Perfect.
Oh, yeah. Go you, mental health proactive. Is an eating disorder serious?
Eating disorders can be potentially fatal. Depends on which eating disorder, though. We're talking about anorexia, where people are restricting. That doesn't mean that all people who have eating disorders can't get married, can't have wonderful, healthy lives. But it depends on the degree. There often are medical complications. There are medical complications related to eating disorders. Used to be the most deadly of all the mental disorders. Now, absolutely. Now opiate addiction has taken over, unfortunately, as being the most deadly. But with that one exception, restricting eating disorders, anorexia. But again, if somebody owns it and says, listen, I have a tendency to say that I, really look good at like 85 pounds, but in reality, I know, like, my mind is telling me, like, I really need to be 115 or whatever it is. So I know that under stress, I tend to restrict. I know that when I feel disconnected from people who are around me, the way that I do it is by purging calories, by over-exercising. So as long as they know that and they own it, I'm less concerned.
So this is a very hopeful message, because basically what you're saying is it doesn't matter what the issue is as long as you own it. Is that what you're saying?
As long as you own it. Yeah, it is. As long as you own it and have the resources to deal with it.
So someone else said, do guys get nervous of a girl who's open about going to therapy?
I don't know. That's an empirical question to me. I haven't done a survey. I think it really depends. Honestly, if somebody tells me that they're going to therapy, though, to me, like you said it before, that could be a very good thing, because they're often growth-oriented. They have somebody who they can speak to. They can own it. They're already in a system, and things are going to come up in life. It's complicated. It's complicated today. Raising kids, dealing with in-laws, dealing with families, dealing with other kids in your class. I mean, in your kids' class, dealing with neighbors, dealing with, family members. I mean, like we said before at the beginning, the base rates for mental health issues are nearly 50% in the United States. And in the frum community, again, we don't have base rates, but the studies that I've done are looking at 25 to 30%, which means you are going to run into these issues. So having a therapist means that you consult with a professional about how to manage these things, either your own, somebody else's. Doesn't that sound like a positive thing to you?
Does to me.
Okay. I'll put it to you this way. Do you go to the dentist?
Me?
Yeah.
I don't enjoy it, but yeah.
But you go?
Yeah.
Once a year?
I go when they email me and say it's time to go.
Right. So once or twice a year. The American Dental Association, I imagine it's the same in Canada, I think it is, says you should go twice a year, at least once a year, to get a dental cleaning, to have a checkup. Okay? So if somebody's going to be freaked out about somebody who goes to therapy, you know what? like has a therapist, like once, just think about it. So it's okay to go and take care of your teeth, but not your emotional well-being?
Well, your brain's a little bit more complicated than your teeth.
So then wouldn't you need more support for that? Then
I mean, I think so. I'm all...
With all due respect to the dentists in the audience, like I just, in terms of priorities, like where should we be putting our resources? So at one point I was advocating for a mental health checkup, that everybody should have a therapist that they go to at least once per year for a mental health checkup.
I think that's a great idea. That's proactive.
Doesn't that make sense?
I'm on board. There's like a hashtag therapy is cool.
There you go.
Viral, I'm looking at if there's more questions. Which addiction is most deadly? We already kind of covered that.
Yeah, the opiates are pretty scary.
So
by the way, on the opiate side and on addictions, if you're going to compare disorders which are more problematic, I would say that substance abuse and alcohol abuse are more serious when they're active. The reason why, though, is because those disorders in particular, they tend to be characterized by denial. One of the almost hallmark features of those is that I don't have a problem, I'm just drinking a little bit. When they're not, they actually have a drinking problem. It's significantly interfering with their day-to-day functioning. It's something that they can't live without. They're dependent on it. This is an issue. And it's sort of like a hallmark sign that, like, no, this isn't a problem. I'm just having fun. So the real reason why I would say, like, stay away from substance abuse is because of the lack of insight. If somebody says, like, yeah, I have a problem and I have to be extremely careful with alcohol, with substances, that to me is, I'd be much less concerned. But that's not typically the case. Typically people, unless they're in recovery.
I mean, we've had like some really fabulous speakers and some speakers coming up that are really like open about their addiction recovery and kind of talk about it as it's a lifelong challenge and some of them are pretty powerful stories, but they all have said that it's a lifelong struggle.
Right. So if somebody's saying that and they own it as an issue, then fine. But typically with active substance abuse, people don't.
Right.
That's not the case with active anxiety or depression or people who are like, yeah, I have a problem. It's OCD. I'm working on it. It's very hard. That's often the case.
So somebody said sometimes people have issues that are never fully resolved, even with therapy.
Yeah. I would say a lot of people. That doesn't mean that, having a close relationship with someone and developing a close relationship doesn't mean that they can't have a good marriage. It doesn't mean that a person can't have a good marriage. If they're willing to do whatever it takes and they have access to care, then things tend to work out.
So someone said it's cultural in Manhattan. Going to therapy is like going to the gym. Great, and thanks. I think guys don't talk about it, though, whereas girls are more open. I don't know. I think guys do.
No.
I think it depends where you are, who you're talking to. About the guys.
I would agree. I think sometimes women are much more guarded about it because of the gender imbalances in the shidduch system. So it's more to be concerned about.
Yeah.
Depends.
And so do you think people need to date longer? People can hide they have issues until marriage, especially if dating and engagement are short. And what if they have abusive tendencies?
Dating longer has its benefits, but it also has its drawbacks. It's not easy to be dating and to be, developing a relationship with somebody without moving towards turning that relationship into a marriage. So that's a lot of stress and a lot of pressure. Not everybody can hack that. for good reason, frankly. I think it really depends on the circumstances. I don't think just dating longer is a solution. In some cases, it is. In some or, they need to work on certain things and they have to postpone. I think you can take a mature approach and extend things by a month or two. Like, I don't have a problem with that at all. In fact, in many cases, I'd support it. But I don't think it's an automatic solution.
Should we go through the questions that were sent in? If we didn't cover them.
Some of them were really tough.
How and when to bring up health history without overwhelming or scaring off the other party? Do you tell? I think you addressed this. Do you tell before you go out or after a few dates?
Yeah, we talked about it a little bit. I said in the mainstream Yeshiva Orthodox community, usually between 3 and 5 dates, there has to be some sort of disclosure. The conversation probably has to go something like, hey, I like where this is headed, but there's something you should know about me. And then just saying the initial facts. And that should be practiced. The person should practice, role play it. When I have patients, in our clinic, when we have patients who have who are about to start dating or are in the middle of dating and who have mental health concerns, we will role play that with them in a couple of sessions. How would the conversation go? And usually it's something like, there's something you need to know about me. I have struggled with OCD for the last several years, and it's pretty much better now. I'm still in therapy. I am on medication. I'm not on medication. Whatever it is, and this is what I'm doing. I have a great therapist. I am working on it. I've come a long way, and I don't think I'll be in therapy forever. But it's something that you should be aware of. And if you have any questions about it, then I'm happy to answer them. And if you want, you're also welcome to speak to my treatment team.
That's a great script. Can you send it and I'll post it so people could just copy it?
You could try. I just kind of came up with it on the spot.
It might be helpful. Here's our dating script.
The dating script, yeah. We usually, it depends on the case. There sometimes are very specific situations. Like one of the things you talked about is where somebody has a parent who has a mental health concern. And how do you disclose that?
Mm-hmm. Yeah, I don't remember which question was that.
Yeah, somebody who even has a parent who had a pornography addiction, or.
Oh yeah.
So that's much more complicated. It's hard to script that, the role play around that. You should know there's something about my family that a parent is dealing with that.
Let me find one. Hold on.
That's a harder conversation. I'd have to think about that actually. I'd really have to think about what's the right approach in that case.
Oh no, it was the guy that was addicted to pornography.
That was after they were married or something?
No, I'm engaged to a guy, and he told me after we got engaged that he was addicted to pornography. I'm really uncomfortable with that, and I think I should break it off. But it seems like he would be a great husband and father, and I've had also mental health issues myself, so maybe I shouldn't be judgmental. But yeah.
That's a tough situation. So we could talk about that one. In that one, I would definitely have her ask him some questions, like, is he in treatment for it? And also, frequency of the behavior. When he says addicted, is that, multiple times a day? Or is it, once a month? Is it, what's the frequency? What's the intensity? When somebody says, I'm addicted to chocolate, which is not the same as pornography, I realize. But, what does that actually mean? Do they really have an uncontrollable urge to eat chocolate? Usually not, right? Usually.
Well, in the frum world, even watching pornography is stigmatized, and so that's 100% a tough one.
Yeah, and there are some advantages to it being, to being so taboo that even low levels are considered to be problematic. There are some cultural advantages to that. I don't want to say otherwise. But what is important is to recognize that when someone says, I'm addicted to pornography, that doesn't mean necessarily that it's at an addiction level. I would want to know what's the frequency of that and what's the intensity of it. And also, are they watching certain things that they sort of are, what's the nature of what they're watching? Is it of a child nature, which is, would be extremely problematic? Are they watching,
Did you go to jail for something like that?
Exactly. Like there are certain things that are, that are illegal. And for that kind of thing, I would be much more concerned.
Right.
I would be much more concerned. But if somebody is, struggling with aspects of, controlling sexual urges prior to marriage, where they're completely not engaged at all sexually, to some degree that's normative. And if they're coming clean to their spouse and one just, prospective spouse, and they're engaged and they just want to say that they're struggling with this and they don't know what to do and they're opening up to them, that could be a really great sign. Or
I thought about it like that.
Yeah, or it could be that they, they really are, masturbating 6, 7, 8 times a day and really hooked on looking at things that are not consistent with their moral system at all. I mean, completely anathema to what they,
right.
You understand? So there's a lot of nuance there.
Baseline might be healthy, and if it gets
yeah, I mean, I'm not gonna recommend use of pornography to that extent, but I'm definitely gonna those kinds of, it could be within the realm of it's not necessarily an indicator that the person's not marriage material.
Okay.
I mean, yeah. Also, we know that they have a sex drive, which can be a very positive thing in a marriage. So
that's a great perspective. Okay. So somebody said from a halachic perspective, they may not need to disclose about the parents.
They might not need to disclose about what?
About the parents.
The parent, that might be the case. I don't know. I have to think about that case, and I probably would consult with.
Yeah, I don't know
about that. The question about the parent was when somebody found out about it from a third source. And if someone's going to find out about it anyway, then sometimes it makes sense to you be the one to say something as opposed to them finding out elsewhere. In which case, it's not a halachic question. It's just a matter of strategy.
Oh yeah, here. This is it. My son was offered to go out with what we thought was a great girl from a wealthy family, but rumor has it her father's a recovering porn and sex addict. He's a frum guy, well respected in the community. I guess most people don't know. I heard addictions run in the family. Should we be wary of the shidduch?
The way it was phrased is like, I heard that he might have a problem. Like, that doesn't sound like any information at all. Sometimes having a parent who's had a mental health concern can sensitize a child to mental health issues and actually make them a lot more able to handle the vicissitudes of life. So I'd be much more concerned and interested in how the child perceives their parents' alleged issue, as opposed to what's going on with the parent.
I like that.
Thanks.
Yeah. Let's see if there's any that we didn't. I have bipolar and it's under control, has been for 2 years now. Do I need to tell the Shadfins about it? I went out with the girl and told her about it on a first date and she was horrified.
Yeah, that's a raw deal. The first date I would not disclose. I don't think there's any reason to disclose on a first date, with almost no exception in any faction of the community. If you have to disclose on a first date, then there's a vetting process in advance and families are involved and they should figure it out, in which case you might not have to disclose at all. I mean, you should disclose still, but I can't, first date doesn't make sense. With regards to telling shadchanim, we spoke about that before. I have some real hesitations about telling a professional shadchan about a mental health history. I've seen people get really burned and families getting burned because of it, because the professional shadchan system is pretty broken. But again, If it's a family shadchan, if it's a family friend, if it's somebody who, you know, who's really acting out of, you know, the best interest of the parties as opposed to financial interest, then I think that there should be disclosure for sure in that case.
Somebody said, how can you honestly know how the parents' problems affected the children?
Probably not. By the way, if you're going to look at the parents, should you look at the grandparents also? And what about, you know, other kids in the family? What about their schoolmates? I'm like, you know, at a certain point, you can't limit exposure to mental health issues.
Shadchans don't hold by HIPAA.
That's exactly the problem. It's not only a matter of HIPAA, it's a matter of just basic professional standards. There are no professional standards in the shadchan world. There's no uniform professional standards. There's no unified body. If you do something egregious and as a shadchan, then there's no license to be revoked.
What's meant to say, or even the perspective of him herself if they had a child. Can you explain that? I'm not sure if I understand. Meira, can you just explain what you're asking? In the meantime, I'm going to ask another one of the questions. How can we get the community to understand mental health and mental illness better so it's less scary and stigmatized?
That I will definitely comment on. Stigma. How do we deal with stigma? I used to think that mental health awareness campaigns and politicking and disclosure and working with, petitioning askanim and rabbanim and, grassroots and, I used to think that was really the way. And I think that has had a big impact, a huge impact. But ultimately, to me, there is one key factor which will destroy stigma more than anything else. And that's providing effective treatments. When people know that there's a solution which is available to their mental health problem, all of a sudden they will say, oh yeah, I have that issue, because now they have hope that they can actually deal with it. Mm-hmm. But until you provide a solution, people are going to stay in the closet. Even if you drag them through the street and say, face the music, there's a problem. Nobody wants to do that because there's no positive reinforcer. Just creating negative, what was that?
Right, yeah. I mean,
creating a negative reinforcer by yelling and screaming and saying you have to deal with this. Okay, eventually you'll get the person to move a little bit, but we're not using positive reinforcement. When I started my clinic in Brooklyn, I opened up an office in Brooklyn and Center for Anxiety office, and I have a waiting room. We have a waiting room there. We're like a communal waiting room, okay? Where people are sitting together in the same room. And when I first opened up and I showed it to my colleagues, they're like, you are crazy. People aren't going to come. You think you're going to have anybody sitting in this waiting room? Do you think anybody's going to come to your office? You just threw away your entire build out. Like you're going to have
because
to
you have a waiting room with people sitting together?
It's called the Center for Anxiety. People are all there for mental health. It's not a medical office. This is a mental health, private mental health facility in the middle of Flatbush. Okay? Do you know how busy we are?
I mean, if I'm there and you're there, then we're both there.
That's the first thing that I showed to. That's exactly what I said. Is that firstly, everybody's hiding from the same thing, so you're all in it together. We have had some interesting situations of people bumping into their principal or things like that, and which I thought
love that.
They actually did. The principal wasn't that happy, but the student was like, wow, okay, I guess I'm not alone. But people have been nervous, and sometimes people are really nervous to the point that I really need to wait somewhere else in the office. And we try to accommodate that, of course, and we understand that and respect it. Although we'll encourage them eventually to, try to make their way. But I will tell you that, our office is jammed. And the reason why is because of effective treatment. People are okay disclosing, if you will, their mental health concerns, at least in a discreet manner to people who are around. If they know that they're getting a solution that works.
It's important. So somebody said exposure to mental health issues makes more sensitive, more kind people who have more emotional skills.
Awesome.
And someone else said, I think it's important for us in the community to say loud and clear and not to let fear keep us from even screaming from the rooftops. Mental health concerns are no different than cancer. It's not a reason not to consider a potential relationship or shidduch.
Well, I'm going to qualify that. You know, is mental health a reason to not consider a shidduch? Yes, if the person's not willing to deal with it.
Right.
You know, by the way, it's the same by cancer. If someone's not willing to deal with, you know, with a cancer diagnosis, then that's probably not a good shidduch either. Right? Like,
Yeah.
it's something that has to be dealt with. Some people don't, right? There are people who just try not to, I mean, it's less common than mental health, but
I think also like what we've been trying to do is kind of give an awareness of different resources and organizations and modalities, and because I think that a lot of people, including myself, every time I talk to somebody, I learn something new. Like just when I think I know everything, I learned something new from like every person that we interview. And I think that just kind of knowing that there's so much more out there is so empowering too, that we, I mean, to me, it's very promising to know that, I mean, we have people booked till February, like a really incredible roster of people, and like, and they all have different things to say, and I think that just raising that kind of awareness that there's hope and resources out there. I mean, obviously, Center for Anxiety. I mean, I want to come hang out in the waiting room because it sounds
come
like
on over.
fun.
Yeah, I see Elisa Tropper just posted that we have chocolate in our waiting room, which we do. So
Really?
you can come and help yourself.
I'm in. When I come to New York, I'll bring you coffee. We'll hang out in the waiting room.
Yeah.
You come. Okay, let me just catch up with the question. So, how do you know how mental health issue affects the person themselves when dating them? How can you really know before being married to the person?
I don't know how much you can really know before being married to someone, to be perfectly honest. Most stuff comes out afterwards. But listen, you got to make decisions based on the information you have in front of you. That's life. Uncertainty is like part of the picture. Like, you never have all the details. But you always make decisions based on the info that you have. That's just...
And you could probably tell on a date if the person is a growth-minded person. Like if they're always, you know, trying to learn more, and if they're, you know,
yeah, if they own their package, you know, if someone can come clean and say like, yeah, I struggle with that.
Let's see what else. We've had people in our OCD support group, 2 Orthodox Jews, who were too glad to discover they were each there. They knew each other. Great room was really nice. There's chocolate. Yeah, I'm caught up.
I know who that is. That's Dr. Yoni Sobin. Hey, Yoni. He's from my Brooklyn office.
Oh, yeah? Nerd therapist?
Nerd therapist. And a fabulous nerd therapist at that. Way to go, Yoni.
Yes, agreed. Thanks for adding that clarification. Okay, somebody else. If only stigma wouldn't be so bad, I would long go get help I desperately need. Can't wait for that day to just let go of that and just go for it.
Go for it now. Be part of the solution.
Therapy is cool. I forgot to say, #therapy is cool.
There you go.
And nerd therapist said you also have candies.
That we do. And coffee, by the way.
You do have coffee? So I don't have to bring coffee.
Yeah, we do. We are welcome to bring, but we do have coffee.
Is it as good as Starbucks?
I think we have a Keurig.
Okay, maybe I'll bring Starbucks.
You can bring your Starbucks.
Thank you, David. Center for Anxiety is an amazing resource for Jews of all colors. I work there and specifically address stigma.
Yes, you do. Thank you.
Awesome. So nerd therapist, we'll book you for February. Message me. Okay. Hope it's okay to ask. I hear what you're saying, but don't you think life/relationships presents enough challenges? Why add the extra challenges being married to someone with mental health issues? That's a great
question. Thank you, Meira, for asking that question. Couple things come to mind. It might be because life has enough challenges that it's important to be open to mental health. In other words, I agree with you, life is challenging enough, but that's actually a reason to be open to mental health issues. Because if part of, and what any clinician will tell you, any mental health clinician will tell you, is that life is really complicated. And it's not easy. And one thing that having a mental health concern teaches a person, if they own it, and if they're working on it, is to be humble and to accept that you're not in control and that it's okay to have a challenge and that that's not going to destroy you. I think when we live in a society that really, and maybe on this point we'll wrap it up, but we live in a society that really values perfection as if we're trying to never fail, to always be on the money, to always be on the ball. And it's just not realistic. It's just not realistic. It never has been. So when people have mental health challenges today and they own them, that often is a sign of humility. That means that they're better poised to be able to handle life's vicissitudes. No, again, like I guess if somebody says like, yeah, like whatever it is, like whatever my package is, I'm willing to own it and deal with it. And if it's not a diagnosable concern, okay, you know, all things being equal, if somebody's just willing to accept it, then to accept life and be, you know, to be ready to handle whatever it is that they have to handle. Then yeah, I think a less serious mental health concern is probably, you know, better than a more serious one. But that just because a person has a diagnosis doesn't mean that they're not marriage material. It's not. That's not in of itself is not, I think, a basis for disqualification.
I mean, some of the most incredible people that I know in my life that I would never want to live without them being a part of my life have what people would call a severe mental illness, and
100%.
I would never like they, as much as they stress me out, they enrich my life sometimes. They enrich my life more than anyone else could. So it's sometimes like you, I'm like it, and I think you're right. It's because of their ability to work that they're always working on themselves, and they're always, you know, getting support, and they really know themselves really well. So they're refreshing to be around.
Right.
And so someone else said, yeah, why would anyone want to marry someone who's challenged like me? Oh gosh, no.
If you have the humility to accept that you're challenged, then you're going to make someone really happy.
That's, yeah. 12-step programs help with destigmatization. That's what
they could.
And do you do referrals?
Centerforanxiety.org. We're busy, but there's always room for more.
In the waiting room.
In the waiting room.
You're going to be there. I'll bring you coffee too.
We don't keep people waiting that long. So.
No? Oh, so it's not like a coffee clutch where you get to hang out with people?
No. Appointments start on time, but we do have a waiting room in case you come early with Wi-Fi.
I'll bring my kids. They'll love it.
Perfect.
Perfect. Thank you so much. This was really informative. And
pleasure.
and we'll be in touch. I really appreciate it.
My pleasure. Happy 2 of coming up.
Oh, right. We didn't even talk about that, but
No.
we wrote about it. It's all good.
There you go.
All right. Bye.
Have a good one.
So much. Bye.
Okay, bye-bye.